All right, today we're going to dive into a really serious, life-threatening heart rhythm, ventricular tachycardia. We're going to break down exactly why it happens, how you can spot it on an ECG, and the absolutely critical steps for treating it.
So to really get why this is such a big deal, let's start with a classic clinical picture, something you might see in the emergency department.
Imagine this. You have a patient, maybe someone who had a heart attack a few years back. All of a sudden, they feel their heart just racing, and then they collapse. So what's going on here? Is it just a simple faint? Or is something much more serious happening? Is their heart beating so incredibly fast that it literally can't fill with blood and pump it to the brain? Well, that dangerous scenario, that's the reality of ventricular tachycardia, or VT for short.
Okay, so to really wrap our heads around what goes wrong in VT, we've got to first understand how the heart is supposed to work. And the best way to think about it is like a perfectly timed electrical highway.
It all kicks off right here with the sinoatrial node, or SA node. This little guy is the heart's natural pacemaker, just sitting up there in the right atrium. It sets the rhythm for everything, usually firing somewhere between 60 and 100 times a minute, starting every single heartbeat.
So from that starting point in the SA node, the signal travels down to the atrioventricular node, the AV node, which kind of acts like a gatekeeper. After that, the signal just explodes out through a super fast network of special cells called Purkinje fibers that line the ventricles.
And because this signal zips down that highway so efficiently, both ventricles get the message to contract at almost the exact same time. It's this beautiful coordinated squeeze that gives you that sharp, narrow QRS complex you see on a normal ECG. It's a clear sign that the system is working perfectly. But what happens when that perfectly paved highway suddenly gets a detour? This brings us to the main problem behind most cases of ventricular tachycardia, something called a re-entry loop. Re-entry is, well, pretty much exactly what it sounds like. An electrical signal gets stuck. It re-enters a pathway it just finished, creating this little short circuit that just goes around and around. And what's the most common cause of this? Scar tissue. Usually it's from a previous heart attack. That scar tissue is dead tissue. It can't conduct electricity, so the signal has to find a new way to get around it.
So here's how this crazy loop gets started. The scar tissue basically creates a fork in the road, giving the electricity two paths to take. One path is slow, the other is fast. Now imagine a premature beat comes along at just the wrong moment. It tries to go down the fast path, but that path is still recharging, so it's blocked. But the slow path? It's ready to go. So the signal travels down the slow path. By the time it gets to the end, guess what? The fast path is recovered. So the signal can now travel backwards up the fast path, and boom, it re-enters the circuit, creating a continuous self-sustaining loop.
And here's the kicker, the really crucial point. Every single time that electrical signal completes its lap around that scar tissue, it triggers a ventricular contraction. So instead of the heart beating at a nice, calm 70 times per minute, it might now be firing at 150, 180, maybe even over 200 times per minute. It's a complete runaway heart rate.
All right, so we know what's happening inside the heart. But how do we actually see this? Let's turn to the ECG and see how this all comes together clinically.
On an ECG, the #1 classic sign of VT is what we call a wide complex tachycardia. Remember that nice skinny QRS from the normal highway? Well, that's gone. In VT, the signal is crawling through regular heart muscle instead of those super fast Purkinje fibers. This slow, inefficient journey makes the QRS complex look really broad and bizarre.
But it's not just the wide QRS. Another huge clue is something called AV dissociation. This is where the atria and the ventricles just completely lose their connection. They start beating independently. The atria are just chugging along with the slow SA node, while the ventricles are racing like crazy with the re-entry loop. And you can sometimes even see this on a physical exam. It causes something called Canon A waves, these visible pulses in the neck veins when the atria try to squeeze against closed heart valves.
You know, it's also worth knowing that VT comes in two main flavors. If all those wide QRS complexes look pretty much identical, we call it monomorphic VT. That points to a single, stable re-entry circuit. But if the shape and the size of the QRS complexes are changing from beat to beat, that's polymorphic VT. And that usually signals a more chaotic cause, like maybe multiple circuits, super low oxygen, or some major electrolyte problems.
Okay, spotting VT is one thing, but treating it, well, that's a true medical emergency. Let's talk about how we get the patient stable.
The very first, most important question you have to ask is this: is my patient stable or unstable? If they're stable, meaning they have a pulse, they have a decent blood pressure, we've got a little time to work with. We can use antiarrhythmic medications. But if they are unstable, low blood pressure, confused, unconscious, we have to act right now with an electrical shock. And that treatment is called synchronized cardioversion. Think of it like a controlled electrical reset button for the heart. We deliver a shock at a very specific time in the heart cycle. And the goal is simple: to just wipe the slate clean, stop that dangerous rhythm, and let the normal pacemaker, the SA node, take back control.
Now, why do we call it synchronized? That's a super important detail. The machine is smart. It's programmed to deliver that shock precisely on the R wave of the ECG. We do this to specifically avoid the T wave. The T wave is a really vulnerable time in the heart cycle, and a shock delivered right then could actually push the heart into an even worse rhythm, like ventricular fibrillation. So once the immediate danger is over and the patient is stable, the focus shifts to making sure this doesn't happen again. This can mean daily antiarrhythmic medications or a really cool procedure called radiofrequency catheter ablation. That's where a specialist goes into the heart and actually burns or ablates the exact little piece of scar tissue that's causing that re-entry loop in the first place.
Okay, that was a lot. So let's boil it all down to the absolute must-know, high-yield points that you need to remember for your exams and for the clinic.
If you remember nothing else, remember these 4 things. First, the definition: 3 or more beats in a row, coming from the ventricles at a rate over 100. Second, the mechanism. It's almost always that re-entry loop around a scar. Third, the ECG hallmarks. You're looking for that wide QRS complex and signs of AV dissociation. And finally, emergency care. If your patient is unstable, the answer is synchronized cardioversion. So, at the end of the day, here's the one sentence to take with you. Ventricular tachycardia is a dangerous, wide, complex rhythm, usually driven by an electrical re-entry loop around scarred heart tissue that requires rapid stabilization to prevent sudden cardiac death.